Angela, welcome to the Center for Universal Oneness. Uh, Angela has uh, a very unique and I think incredibly necessary work that she does for people. And I'm going to let her describe it rather than talk to it in any way myself, except for to say it's about empowering end-of-life options. So, Angela, welcome, welcome, welcome. You are, we'll come back to some more bio in a little bit, but let's get you started and make sure you're unmuted as you go ahead in there. Angela, welcome.
Thank you. Let me go ahead and share my screen. Can everyone see the PowerPoint?
Yeah.
Yeah, okay. So thank you so much for having me today. My name is Angela, and I am the States Advocacy Manager for Compassion and Choices. And today we're going to talk about medical aid in dying. As we go through the presentation, you'll see we do a lot more than just medical aid in dying, but that's what we're going to focus on today. So, Compassion and Choices is the nation's oldest, largest, and most active nonprofit working to improve care, expand options, and empower everyone to chart their end of life journey. And so, this is our mission statement. We believe in patient directed care, where patients and their healthcare professionals should work together as a team. Patients should have the ultimate decision of choosing treatments that align with their individual priorities. So, just an overview of Compassion and Choices. So we have an end of life consultation program. And so this is the phone number for it, this 1-800 number. And so anybody in the country can call this number. You can call it about yourself, or you can call it about, a loved one, someone you care about. And you just talk to an end of life consultant who will provide you with free information and resources and education to help you navigate any kind of end of life experience that you're having. We have an end of life planning resource. It's going to be the second to last slide. We'll have that website. We have a really great booklet that you can either download for free, or you go in and you put your address on the website and we'll mail you a copy of the booklet. It's about 44 pages long, and it really walks you through identifying what your values are, what your goals of care will be, so that you have a better chance of having an end of life experience that you want. We do education, community education, and advocacy. So I'm going to talk more about the advocacy side of things today, because one of the things that we do is pass legislation to allow for medical aid in dying. We have a clinical engagement team that really works with doctors and nurses and social workers to educate them on this process. And then a community engagement team, because one of the things that we've really identified is that there's a lot of health disparities at the end of life. So we really want to make this as inclusive as possible. And then we have a legal and policy team, and then a storyteller program. So we have found that people sharing their personal stories is the most powerful tool that we have to get legislators involved, to help other people understand why this is an important topic. And anybody that has any kind of story about end of life, we welcome them all. You can just go on our website and submit it that way, and then somebody from our storyteller program contacts you. And so this is a quote from the book Being Mortal, and it says, life is meaningful because it is a story, and in stories, endings matter. So research has shown us that people want to experience an end of life at home with their loved ones, with their pain and discomfort managed, to have their spiritual needs and values respected, and without being a devastated burden for their loved ones. However, in reality, 60% of Americans die in acute care hospitals and another 20% in nursing homes. 1 in 3 near the end of life receive non-beneficial treatments, often painful, uncomfortable, and futile treatments that have no hope of improving health while compromising quality of life. And so this is just a little cartoon that says that you've got 6 months, but with aggressive treatment, we can help make that seem much longer. So medical technology advances have been amazing over the last 50 years, and it's really changed the practice of medicine. So these advances have saved lives, they can increase access to care, and they can improve quality of life. However, too many people with terminal illnesses and nearing the end of life endure needless medical interventions. Too often, the end of life care system is a conveyor belt that people get on, filled with intensive treatment that robs them of their remaining quality of life. And so Stanford University also did a research study on whether or not doctors and patients differ when they use the word treatable. And so what they found is that doctors say treatable when they don't want to say incurable. When a doctor uses the word treatable, they simply mean that there is treatment that can be applied. Doctors do not mean to imply that the treatment is likely to succeed, or that if it does succeed, that the disease will go away. They don't even mean that the treatment may prolong life. The chance that treatment could prolong life may be very small, and a doctor will still use the word treatable. Research found that patients hear the word treatable and often walk away with a positive message about their future. They hear that the disease can be cured or at least contained, so it does not seriously diminish their quality of life. If the doctor also shares dire news about the overall prognosis, patients and their loved ones and their surrogate healthcare providers altogether often discount it, and they walk away only hearing the good news of treatment. So researchers concluded that the physician use of the word treatable may lead patients or their healthcare surrogate providers to derive unwarranted good news and false encouragement to pursue treatment, even if the doctor has explicitly stated information to the contrary. So this very unfortunate confusion over the word treatable can be avoided. Most people want to make plans and treatment decisions knowing the realistic benefits, burdens, and full risk of any course of treatment. So end-of-life options in the US. So I do want to point out that while I mentioned that these are end-of-life options, I never look about it as planning for your death, which I think most people do. I really look at it as planning for how you want to live at your end of life. So I also want to note that these end-of-life options are not in any particular order, and they can also be used together. So you can always pursue some or all treatment options available to you. You have the ability to choose all treatment options or choose to receive some treatment, but nothing too aggressive. So for example, you could take antibiotics for an infection, but not choose to have surgery. So palliative care, one of the things I want to really point out, because a lot of people get palliative care and hospice care confused, is that palliative care is not for people who are terminally ill. It's for people who have a serious illness. So this is a specialized medical care for people living with serious illness. It consists of a care team that can include a physician, social worker, nurse, chaplain, pharmacist, and other trained specialists. Palliative care is based on the needs of the patient and focuses on symptom management. And you can receive palliative care in addition to curative care. So you can still be seeking treatment options. The care team can also work with caregivers to provide education and tools, which has been shown to greatly reduce stress and burnout for caregivers. So example of palliative care could be pain medication or massages to treat pain caused by treatments, spiritual and emotional support, or physical and occupational therapy. So this option, again, it's appropriate for anyone of any age during any stage of the illness. It's estimated that only 11% of people receiving palliative care are in their last year of life. Palliative care is often covered by insurance. However, the length of time and the services offered can vary depending on what kind of insurance you have. So hospice care is compassionate care at the end of life. So in order to be referred to hospice, a physician must determine that you have 6 months or less to live. And the goal is to maintain or improve quality of life. So again, similar to palliative care, it involves an interdisciplinary team of caregivers that often includes doctors, nurses, home health aides, social workers, chaplains, trained volunteers, and others. For people who have an appropriate medical referral, the cost of hospice will be covered by Medicare, Medicaid, VA, and other third-party insurance. And then hospice can take place wherever the person resides, and most often in the home. Or palliative care, they are going into like more community settings, but most often people receive palliative care in a hospital setting. And then hospice care also provides bereavement counseling, family support, and end of life planning. So stopping or refusing treatment. So this includes discontinuing medications or foregoing treatment. So you can make a decision to stop, going to dialysis. You can discontinue medications that manage chronic conditions. If you're taking heart medication, you can always make a decision to stop taking that, stop blood transfusions. And then also, if you, we talk about this a lot with people who have a fear of, uh, receiving a diagnosis of dementia and then living like a long life where they don't have like their decision-making capabilities anymore, and kind of trying to figure out how they want to live their life at that point. So one of the things we talk to them about is like, you can, talk to your loved ones that if you were to get to a stage like that and you were to be diagnosed with pneumonia, you don't have to be treated for pneumonia. You can let them know if I get to a point like that, where I'm no longer, able to take care of myself, if I'm in a nursing home, if I no longer, know my loved ones, and I get diagnosed with pneumonia, just provide me with comfort care and don't treat me for pneumonia and allow me to die naturally that way. Palliative sedation. So this is often called terminal sedation, and this is used in rare circumstances. This is typically not something that the individual will ask for. It's usually a doctor will bring it up. And this is when pain medication and sedatives are not enough to reduce the symptoms at the end of life. So it must be medically managed. And at the same time, the person also stops receiving nutrition and fluid. And so a way to think about this is sometimes at the end of life, you do have the right to request as much pain medication as you want at the end of life. And people will kind of drift in and out of consciousness. With palliative sedation, the goal is to put the person into a deep unconscious state until their death, which usually happens within 1 to 3 days. So voluntary stopping eating and drinking. So this is an option that is legal in all 50 states to people who are over 18 and have decision-making capabilities. So this is when a person makes a decision that they want to stop all food and fluid and experience a death that is consistent with the body's natural dying process. So this is a patient-directed approach, and so the patient decides when they will start VSED. And then if they make a decision that, they do want food or fluid again, their caregivers must honor that as well. So there's a lot of thought, and I just think like people, this isn't like a decision that people just usually make in like a week. They usually plan ahead for this, and they'll have conversations with their caregivers too, and say like, if I say, if I wake up and I say like, I really want some eggs and bacon, I have a conversation with my caregiver ahead of time and tell them like, recognize that you have to honor what I'm asking you, but you can always remind me that you said you wanted to do voluntary stop eating and drinking. Is this still what you want? And then I can say like, oh yes, that's still what I want. I don't want eggs. And then we're going to move now into talking about medical aid in dying. So medical aid in dying, it allows for terminally ill adults to request a prescription for medication from their doctor, and to get the prescription from their doctor to bring about a peaceful death. So to be eligible, an individual must meet 4 criteria. So they must be an adult, so 18 years and older. They must be terminally ill with a prognosis of 6 months or less to live, which is the same criteria for receiving hospice. The person must be mentally capable, so they must understand what they're requesting and be able to make their own healthcare decisions. And then they must be able to self-ingest the medication. So most of the time people do this, it's basically like a mix of opioids, and they will usually mix it with, apple juice. It tastes really gross. It's very bitter, is what I've been told. So sometimes they'll mix it with, I've heard like raspberry sorbet is pretty good, and then they'll ingest it that way. And so some of you may be familiar with Brittany Menard's story. So Brittany Menard was a 29-year-old woman with terminal brain cancer, and she touched the lives of millions of Americans by talking publicly about her desire to have a gentle passing and to not suffer through her last days. Her family was forced to move to Oregon, where at the time medical aid in dying was authorized. It wasn't authorized in California, where she was living. And in doing so, she inspired millions to speak out in support of the rights of the terminally ill. And I have just a little video clip too for it. Let me see if I can get this.
I think the audio might not be sharing.
It's not, the audio's not working.
Can anyone else hear it?
Can you not hear it?
No,
No.
but it might be when you
No.
share that option to click share audio.
Oh, let's see. Share.
Because if you exit the share and come back in with share audio.
Let me see if I can do that. Stop share.
And this should be at the bottom.
I'm not sure, but I can put it in the link if anyone wants to watch it later. And I can share with you guys about her story.
You
I don't
could
know
just
why.
go with the closed captions.
Could you see the closed captions?
Yes.
Okay. Okay. Sorry about that.
I'm not seeing any closed captions or hearing anything. Is anybody
No.
else?
Actually, why don't I just share it?
Oh, that would work. Okay.
Yeah.
I'll put it in the chat.
Yeah,
When the pandemic hit, I was very I did not want to learn Zoom. And now I'm like, man, I really should have gotten with it. Oh, you have it? Okay.
Yep.
Okay.
The thoughts that go through your mind when you find out you have so little time is everything that you need to say to everyone that you love. So after getting married is when I first started experiencing the headaches, and they were quite severe. And I didn't understand them because I had never had anything like that before in my life. Right when I was diagnosed, my husband and I were actively trying for a family, which is heartbreaking for us both. And then I was diagnosed this past New Year's. We went away to the wine country for kind of a New Year's Eve celebration, and by Jan 1, the following day, I was diagnosed with cancer and told I was terminally ill. I was told I had a grade 2 astrocytoma, and was told anywhere from 3, maybe 5, up to 10 years to live. I have to tell you, when you're 29 years old, being told you have that kind of timeline still feels like you're being told you're gonna die tomorrow. 70 days post-op, I went in for another MRI and was told I had had a grade change. They were looking and saying it looks like grade 4. Which is the worst and most aggressive form of brain cancer. It's called a glioblastoma. So that was a major shock to my system and the system of my family, because it went from having potentially years of time to being told I had like 6 months. My parents spent a couple months, they just wanted to search for a miracle.
In the beginning, I hoped for everything. First I hoped that they had just the wrong x-rays, the wrong set of scans. It was all just a big clerical mishap. Your brain will do really strange things to you when you don't want to believe something. You will come up with fairy tales.
I don't wake up every day and look at it. It's in a safe spot, and I know that it's there when I need it. I plan to be surrounded by my immediate family, which is my husband and my mother and my stepfather and my best friend, who's also a physician, and probably not much more people. And I will die upstairs in my bedroom that I share with my husband, with my mother and my husband by my side, and pass peacefully with some music that I like in the background.
Between suffering or being allowed to decide when enough is enough, it just, to me, makes it provides a lot of relief and comfort that, okay, that option is there if and when we decide, or she decides that it's time.
I can't even tell you the amount of relief that it provides me to know that I don't have to die the way that it's been described to me that my brain tumor would take me on its own.
Death with dignity allows for people who are in the predicament of facing a lot of suffering, that they can decide when enough is enough.
Brittany's always been kind of bigger than
You can
life.
go ahead and stop now if you want.
She's
Thank you. Let me go back to my screen. So you may have heard of Brittany's story before. She decided that she wanted to speak out because she really also felt it was ridiculous that she had to move to a new state just to be able to access this. And this was in 2014. And so she was on the cover of People magazine. I remember reading about it at the time and just thinking like what a sad situation to be in. But like how like empowering it was for her to be able to make this choice. So after this really went national. And in 2015 is actually when they really started working in California, because it inspired the California State Ledge, because she was a California resident, to really start focusing on passing their medical aid in dying legislation. And this also helped propel just a series of national bills that were called the Brittany bills across the country, where we have just seen continuously just like almost half of the country is introducing medical aid in dying legislation. So medical aid in dying right now, 1 in 5 people now live in a state where medical aid in dying is authorized. So as you can see, Oregon was the first. And I often have people who only think that this is an option in Oregon. My husband has a lot of family in California, and when they find out what I do, they say like, "Oh, like what they do in Oregon," and I'm like, "And in California." Um, and so, but it had been a long time, so we went from 94 to 2008, where the second state was Washington. And then Montana was actually a decision made by the state Supreme Court. And so they made it so that medical aid in dying, they said that this was a right, that every citizen in Montana had the option to choose this. So different than in these other states where we have gone and passed legislation, um, Montana just kind of authorized it. So they don't have the same kind of legislation requirements that I'll go into that the other states have, but they basically follow whatever Oregon is doing. Vermont passed in 2013, and then as you can see in California was 2015, and then it just gone up from there. So currently, this is what it looks like now. So all of the states that are in dark blue have medical aid in dying legislation, including Hawaii down there. And then Colorado has medical aid in dying, but we're doing an improvement bill this year there. So initially, every legislation was introduced the way Oregon's bill was. And part of that included a 15-day waiting period. So you would make your first oral request for medical aid in dying, and then you would have to wait another 15 days before making your second oral request. And back in the 90s, they thought like, well, if we pass this, people might rush into this. And so we want to make sure this is what they really want. So we need to give them this like waiting period for them to determine. What we have found out from research over the last 25 years is that, you know, similar to Brittany's story, she was 29 years old when she passed away. She did not just say like give up on life. She had tried lots of different treatment options first. But when it becomes clear that, you know, there is not going to be a cure and that you are going to die is when people typically start thinking, well, what do I need? You know, one of the things that Brittany was very nervous about is she was having really big, bad seizures, and just extreme headaches. And she just didn't want to have it where it was like, you know, something that she considered to be so unbearable. And so, which is the state that most people get into when they then go and ask for medical aid in dying. So what we found is that a lot of people were actually dying during that waiting period because they were waiting so long. So in Colorado, they still have a 15-day waiting period right now, but they have legislation going through trying to reduce it to 7 days. In California, there's a 48-hour waiting period. In Hawaii, they have a 5-day waiting period. But if the healthcare provider doesn't think that the person will live that 5 days, they can waive it. So all states are a little bit different, but have like the same general guidelines. So everything in teal is where medical aid in dying legislation has been introduced this year. So Missouri, it was introduced this year, but I don't think I'm not sure if your session is still going, but it's not, we're not hopeful it's gonna move very far in Missouri. But a lot of it we just have to go out and educate the community a lot about it, because I think when people hear about medical aid in dying, they get like these thoughts about what they think it is. I grew up in Michigan. My mom is a nurse. We watched Dr. Kevorkian's trial. My mom was raised Catholic. She's not Catholic anymore. But I was young at the time, and I remember saying to her, like, so he's killing people? And my mom was like, well, these people are dying and suffering, you know, like she kind of saw this gray area there. And when I took this position, I actually thought she'd be so excited for me, because I just remember her having so much compassion for Dr. Kevorkian during that time. And she got a little nervous, and she really had to understand what medical aid in dying and how it was different than what Dr. Kevorkian was doing. You know, and she just said, like, as a nurse, like at first she thought I wouldn't be able to do that to someone, but then when she found out you're just giving somebody the medication and they're dying anyways, and then they're self-ingesting. She's like, oh, I would be able to do like participate in that process. So we do a lot of education before we as an organization run an actual campaign in those states. So right now, they introduced a bill in Illinois, and it's been 10 years in the making before they've introduced this bill for the first time. And so we're hopeful it might pass there. And then in New York, they have been introducing a bill in New York for the past 8 years. And you might think like New York seems like a pretty liberal state, but there's like, you have to have 80 legislators agree to the bill, and like they're consistently climbing up. But like last year, I think they were at 76. So I think they think that they have the full 80 this year that they need. And then I also want to point out that, so I mentioned we have a legal team. So in Oregon in 2022, we had filed a lawsuit because if you're familiar with this area, Portland's a big city, and then there were people living in Washington right over the state line there, that were getting all of their treatment in Portland. It's like a 40-minute drive. When it came time when some of the patients were dying and they were eligible for medical aid and dying, their doctor that they had been seeing in Portland wasn't able to prescribe to them because one of the parts of the legislation is that you have to be a state resident. And so even though medical aid in dying is authorized in Oregon and Washington, the provider wasn't able to prescribe. So our legal team came in and filed a lawsuit on behalf of the physician, and they decided to settle with us, and said that, like, yes, you're right, this should not have the state restriction on it, but like still pass it through the legislation. And our thinking behind this was, at the time, medical aid in dying was the only medical procedure that has a state restriction on it. And we also think that it really lends to like stigmatism if you're saying that you have to be a state resident for this, but you don't have to be a state resident, to go to Texas and get cancer treatment options. And so similar to that in Vermont, because all of these states are so close to each other, we had another case like that. So we filed a lawsuit in Vermont to remove the state residency. And they said, this should go through the Vermont state ledge, which it did. And this was in 2023. And so they removed the residency, reduced the waiting time in Vermont. And then the governor had signed that to approve it. And so we talk about this, it becomes kind of, it seems like it's a partisan issue if you go through the state ledge. I mentioned the governor signed it in Vermont because he's a Republican. In Nevada last year, they only have their state ledge every other year. And so it went through the state ledge. And then at the very last minute, the governor vetoed the bill, saying that hospice provided enough care at the end of life. And so we'll be introducing another bill in Nevada next year. And we have a Republican sponsor for that. So we always say end of life is not partisan. I'll show you some polling where it is supported amongst all different populations.
Angela, can I ask you
yeah.
a quick question? I don't like to break in like this, but I think it's important. I know that California has, I think, removed its residency requirement, and perhaps Washington and Oregon too. Is that correct?
California has not. So Oregon has, and Vermont. You're on mute. Oh, sorry. Yeah, it's Oregon and Vermont. And then when we introduce new bills, we try not to include any residency, because that wasn't our initial bill, with this residency requirement in Oregon. Because again, this was in the 90s, and they were just trying to be put as many restrictions on it as possible. And I will state, one of the things that happened too is after they passed the law in Oregon, the Supreme Court made a decision and said that what they consider, I mean, if you look it up, they term it assisted suicide. They say it is not one of our fundamental rights federally, but we can do it state by state. And so that's why we have to go state by state and do this. And so, oh, go ahead. Another question?
I just said thank you.
Oh, yeah. So some core guidelines. So to meet the standard of care, 2 doctors must confirm that a patient has 6 months or less to live. And initially, again, when we first started doing this, we were saying it had to be a physician. And now our bills will say if you have the scope of practice. It gets really interesting when you get into the states because, like, you know, the different groups want to be able to like hold their territory around it. So like the doctors are saying like, well, you know, we are specifically designed to do this. So advanced practice registered nurses, we don't also want them to be participating in this, or physician assistants, even if it is kind of within the scope of practice. And so the different associations kind of fight amongst themselves to see like who they believe should be doing it in the state. So in New Mexico, they have allowed advanced practice registered nurses and physician assistants. And if you've been to New Mexico, it's a pretty rural state. And so they thought it was really important because you might not have access to a physician in parts of New Mexico where an APRN or a physician assistant might help. Same thing with Colorado, it can be very rural. And so in our improvement bill, it used to just be a physician, and now they wrote in to have advanced practice registered nurses. And they tried to add physician assistants, but the Colorado Medical Society wasn't okay with that. So that there was just a bunch of fighting. So if you've ever had to try to pass legislation, you know it's all about trying to make compromises to get things through so that we can, you know, make it as accessible as possible. So again, the requirements will vary slightly by state. And so then you have to be mentally capable. So we often get questions about this. If I have Alzheimer's, can I use medical aid in dying? So no, because you can, if you have cancer and you have a 6-month prognosis with your cancer diagnosis, and then you also happen to have a diagnosis of dementia, but you still have your decision-making capabilities, then you could still possibly use this option if your doctors approve of it. But just for like Alzheimer's alone, that wouldn't be an eligible diagnosis, because by the time you have your decision-making capabilities, you won't have that 6-month prognosis. And by the time you have a 6-month prognosis, if it's just Alzheimer's, you won't have your decision-making capabilities anymore. And so physicians are also experts at determining their patients' mental capabilities. Doctors are specially trained to be able to assess whether or not patients have mental capacity to make these decisions. However, if either one of these doctors is questioning it, then the patient will be referred to a mental health specialist to be evaluated. And then additional guidelines that vary by state, as I mentioned, will be the waiting periods. There has to be witnesses. You have to do a signed written request and have witnesses sign it. One of them cannot be a family member, cannot be in any way, you know, be eligible for any sort of like estate. Sorry, it's kind of early in the morning still for me, but any wills or any, you know, any additional finances that they might get from that. And then most states, with the exception of Montana, because they didn't actually pass legislation, they also report every year to the Department of Public Health about who is using medical aid in dying. So we do have some information on that. And this is just a report from 1998 to 2002. So we know that almost 14,000 individuals have received the prescription, and 8,700 have died from self-ingestion. So one of the things that we have found out is that when people get this medication, about a third of them, and we've seen this, it's consistent across all the reporting, that a third of the individuals never actually ingest the medication, but just having the medication has reduced their stress and anxiety around dying, knowing that if it got too bad, they had this option. And they've been able to spend the remaining, days or weeks just really valuing the time with their loved ones. So 51% are identified as male, 92% are white Americans. So as I talked in the beginning too, we've just definitely recognized there's health inequities at the end of life, which is why we're focused really on making this more inclusive. 88% are enrolled in hospice. And then the 3 top underlying illnesses are cancer is 70%. And then neurological disease, so that would be like ALS, would be 11%. So that's, again, cancer is primarily what the people are requesting this for. And then cardiovascular disease is at 7%. And then just some information about medical aid in dying. So it is a trusted medical practices, and it's been legal for over 27 years, and there's never been any cases documented around abuse, any coercion, or any criminal disciplinary charges have been filed. There is also in the laws, if somebody were to ever try to coerce somebody into this, they would be charged with felonies. So medical aid in dying is all about patient autonomy and the person having agency over their own body. So again, the patient is in charge, so they request the medication, they take it, and they can also change their mind at any time. They don't even have to take the medication once they get it. It improves end-of-life care. So studies show that in states where there is medical aid in dying, that it has improved end-of-life care. There's better physician training. We hear all the time that, especially from nurses, that the doctors say that they're good about talking about end of life, and the nurses are like, so it has improved better conversations around end of life, starting about talking about dying sooner. And part of that, I think, is like doctors they primarily go into this because they want to heal others, right? And so there is this like, thought process that, if somebody's dying, sometimes the doctors feel like I failed this person, right? And it's not a failure because we all die. This is just part of life. And then it also helps more people than choose to use it. So less than 1% of deaths are in states where medical aid in dying is authorized, are from medical aid in dying. But people in these states that know that this is an option, even when they get diagnosed, very early with a serious illness, it kind of also just helps relieve their fear and anxiety, even if they're not even thinking about choosing it, because in the back of their head, they're thinking, well, this is an option that I know that I won't have to suffer. And then just a few additional information about medical aid in dying. So it's voluntary. Some doctors don't even bring it up as an option. When somebody does, if I went in and asked my doctor for medical aid in dying, it is also part of the law that they have to go through all of my other end-of-life options and treatment, so that I'm fully informed and can make informed decisions. So that I can choose to use it or choose not to. Again, I can go through the whole process of requesting the medication and never use it. It's also optional if doctors want to participate in this process. So if a doctor is uncomfortable with providing medical aid in dying, then they don't have to write a prescription for it or participate in the process. And same thing with healthcare systems. So primarily we get a lot of pushback from, Catholic hospitals will not participate in this option, but that's primarily where our pushback comes from, is from really the Catholic Church. But I'll show you a little bit later that in general, it's like 70% of Catholics do approve of medical aid in dying. It's just the Catholic Church that doesn't. And then medical aid in dying is not euthanasia. So euthanasia is illegal everywhere in the US. And this is when somebody else, like a third party, typically a doctor, would inject you with the medication. And so again, and this can be voluntary or involuntary. So again, medical aid in dying, one of the core safeguards is that you have to be able to self-ingest the medication. And then medical aid in dying is not suicide. So it is, a lot of times our opposition will still call it assisted suicide, or physician assisted suicide. And we really, really think that this is misleading and just factually incorrect. So in the law as well, when we pass legislation, medical aid in dying, it says that it's not suicide, and on your death certificate, your cause of death is listed as the underlying illness. It doesn't affect your wills, or any sort of insurance that you have, which if you complete suicide, sometimes that will. And then we also think that, when we talk about medical aid in dying, people also have the right to forego other kinds of end of life options, such as life support, cessation of hydration and nutrition. And people don't refer to that as suicide, which is the same thing as medical aid in dying. And again, going back to Brittany's story, she really wanted to live. She did not want to die. She had a disease that was robbing her of her life, which is when she chose medical aid in dying. And then this is just some data around it. So again, you can see it's 85% of Democrats support it and 69% of Republicans. Across the whole country, it's 74% of people support it. When we look at white Americans versus non-white Americans, it's still 65% of non-white, so still over half. When we look at non-religious, it's 84%. As I mentioned, the Catholic Church is against medical aid in dying, but Catholics support medical aid in dying 70%. And then here, just, liberal, moderate, conservative, you can still see it's over 50%. And this is from a Gallup poll in 2020. We do a lot of our own polling too, but I know sometimes people like to see the outside stuff. And then, as I mentioned, we have a whole website dedicated to resources, and it's just compassionandchoices.org. I find it best to just Google stuff. So I put Compassion and Choices, Plan Your Care Resource Center, and it will take you to this page. But I mentioned that medical aid in dying is not an option for people who have Alzheimer's and dementia. But we do have an advanced directive, like an addendum to your living will, that it's about 15 pages or 15 questions, and you just mark what kind of life support you want if you're living with advanced dementia. So you can say, if I'm living in a nursing home and require 24-hour care, do I want full life support? Do I not want anything aggressive, but I want to be treated for acute care? Or do I want to just receive comfort care at this stage? And you just go through and mark what options you want, and then you print it and attach it with your advanced directives. And that is it. Does anyone have any questions?
Angela, we have a period after the service called Coffee Talk, where we have people hold their questions till then. If you
Okay.
could stay for a few minutes with us? Thanks.